of your licensed capacity, not 50% of your participants, but 50% of your licensed capacity. However, when you're looking at these individuals, 65 years and older, if they live in a nursing home or congregate living setting, any age with any of these underlying medical conditions, and these are listed out in the guidance. So a chronic lung disease, moderate to severe asthma, serious heart conditions. If someone is immunocompromised, such as they have HIV, AIDS, or have cancer and are receiving chemo or something else that will cause their immune system to be suppressed or compromised. People that are obese with a BMI of 40 or over, diabetics, and chronic kidney disease undergoing dialysis. So these persons are encouraged to stay home. They don't necessarily have to, but they are encouraged to because they are at greater risk of complications from COVID. Not necessarily at greater risk of contracting it, but when they become ill, greater risk from having a serious outcome or a compromised outcome from COVID. One of the things that we were talking about yesterday and Roni brought up was that we need to add a right to the participants' rights. And there is language right in the guidance. And the language in the guidance is really on page 2 of the guidance, kind of halfway down under subsection 1. So that we have to amend those and get those rights out, that the participant has the right to make an informed choice about whether or not they're going to receive services or whether or not they want to stay at home, because they can do either one of those during the peacetime emergency. And that right exists even if they are not an at-risk person. So anybody in your program has the right to be able to make that decision on their own. So we need to inform them of that right, and then we need to inform them of some other things like the at-risk populations, et cetera, et cetera. So they have to have some COVID information. One of the things that we talked about putting together yesterday, Roni and Terry and I, was sort of a package of information that should be sent to participants and their responsible party, because we do have to send them a copy of the COVID plan, the emergency plan that we put together for adult day services. They should have information on COVID, the disease, and then they need to have information on this new right. So we're going to try to put that package together and group them in under a heading so that you know what package should be put together and sent out to families. I also know that one of the pieces of information that we're going to be working on is we're going to be coordinating to put together a communication to your participants and responsible parties about all of this. We have communication template letters for congregate settings, and one of the things that Roni asked for was a similar communication out for adult day programs. So when you're looking at people of who to bring back, one of the things the guidance says is these are the people that you cannot bring back. So anybody that's living in a housing with services establishment or an assisted living, a licensed adult foster care, or other community residential setting licensed under 245D. So these individuals, they have outlined or called out because they are already in a situation where they are receiving some care or some oversight based upon a licensure or a registration. And so what they really want us to do is focus on those participants that don't have otherwise prearranged care in a licensed or registered setting, licensed or registered with the state of Minnesota. So those are the people that we can't bring back yet. So we have to look at other people outside of those settings as we're prioritizing participants to return or asking whether or not they want to return at this point. Prior to resuming services, there are a few things that we need to have in place. So number one, there is a DHS notice of resuming operations paperwork or form that should be filled out and submitted back to the Department of Health. Number two, we have to understand the MDH, the DHS, and the CDC guidances, including infection control guidances and congregate care setting guidance. So DHS has given us reopening guidance, but we also have guidance for congregate care settings, including adult day services, foster homes, and other group settings that we will have to abide by. And that's one of the reasons that we have the coaching room every week, because these are things that have been out there for a while, but not things that any of you have had to be held accountable for or have been asked to know. And so this is a good forum to be able to ask those questions about guidances from the CDC or MDH. There is a COVID preparedness plan word template that is referenced within the reopening guidance, and that also needs to be completed. It needs to be posted within the program, and it needs to be sent out to a copy to the participants and their responsible party. So that is one of the things that should be priority now, is creating that COVID preparedness plan and determining whether or not you're going to reopen, and if so, getting that notice of resuming operations form filled out. Lastly, there are some policies that we need to have done. So there's a COVID-19 staff training policy, a participant screening policy, which I have to review today, an active COVID-19, well, COVID, if you look at my typo, 19 policies on personal protective equipment, which I have one of those we'll go through today, transmission-based precautions, cleaning and disinfection, arrival and departure protocols, and transportation. So those are all of the policies that they have called out within the guidance that we need to be able to have in place. So should your community or your program be surveyed, you have those and you're able to pull those out and provide those to the regulators when they come into the program. So those are the highlights from the ADS reopening guidance, and I will go through the policies next. But before we go there, I'm wondering if anyone has questions to this point.
Kari, a question came in through the chat about providing bathing services to clients who reside in congregate settings.
Do we normally do that? I mean, are we talking about bathing within the program or going to their home and doing it?
That's a good question. Shauna, can you unmute and kind of fill us in a little bit more?
We were wondering if we can go to a congregate setting to provide the bath that they normally would have been getting at our adult day service. The congregate setting is not allowing the clients to come here, and per the policy that just came out as well.
Okay, and is that something that you would normally do, Shauna?
No.
Okay, I would say then my best guidance is no, that wouldn't be something that the adult day provider would do. That would be something that you would want to make sure that the congregate setting is aware of. And if that participant needs a bath, that's something that the congregate care setting should be doing for them or lining up for them.
Okay, thank you.
Yep, you bet. Looks like Darcy has a question. Are we still able to see clients one-to-one in the setting through alternative adult day?
Yes.
And you're not in Minneapolis, right, Darcy?
Correct.
Okay, then yes, you are.
So again, you could still continue to see them one-to-one up to 4 hours per day. The rule with having to provide a lunch, that's only with the new guidances.
So,
go ahead, Ronnie.
Yeah, so we're actually drafting a letter to DHS to try and clarify some of those types of things. It's my understanding that you can still see clients in the center one-to-one. Now given those new requirements around meals and timing, we'll need some additional clarification on that, but I haven't seen anything to date that indicates that you cannot continue to see clients one-to-one in the center.
Okay, thank you.
Any other questions before I pull up a policy? Okay. Then I am going to pull up the first policy that we have for personal protective equipment sourcing and optimization. This just says that this is a bunch of words to say that we base this on CDC, MDH, and CMS guidance is, and that it's general information, and you will need to go in and make sure that your policies are updated for your settings. So we've given a template that we think covers most, but we know it won't cover all. So you'll have to go through and just make your updates. So the interim PPE sourcing optimization and alternative policy. So the policy is so that, healthcare workers, visitors, vendors, everybody has appropriate equipment, personal protective equipment when they're in the program. It lists.
Sorry, can I interrupt for 1 sec and ask that you make your screen just a little bit bigger?
Sure. I can't, you guys, I'm so sorry. I tell this to everybody. I can't tell because this is my desktop at home and I have a massive screen, so everything looks huge to me. Is that better, Roni?
Yeah, that looks great.
Okay. So then we list out the PPE that we've got and talk about source control as an alternative for conservation technique for PPE. And source control, when we refer to source control, we're referring to the cloth face masks. So one of the things that we have so we're gonna run through the procedure really quick. If you have feedback, if you please type it into the chat, I would super appreciate that, because as I have told everybody, and I've told Roni, I'm not an adult day expert like Roni is. And so I took a best stab at this. And certainly if we need to make other modifications to fit adult day, we absolutely will do that. So we need to monitor the PPE supplies on hand and update the information. What most people have done is they have they've created a document that is just an inventory list. So you know what you've got on hand, and you know whether or not you're able to safely continue to operate with the PPE that you've got. If at any time you are unable to procure more PPE, or PPE is running low, then we would go to number 3 and talk to a regional healthcare preparedness coordinator. And you'll want to put who your RHPC is here. We did put a link here to the state page so that you can see whatever county you're in and who your regional healthcare preparedness coordinator will be. So if you're running low on PPE and you can't get it through traditional means, then you'll be able to put this in and contact those regional healthcare providers to let them know that you're running low on PPE. And usually what they ask is that you contact them when you're down to a 7-day supply. That's normally the drop off. Then you're just going to have a statement that says the program will make available to employees the PPE necessary for them to do their job. If they're unable to locate it, you'll follow the optimization strategies. And there is what I can add in here is a link to the CDC optimization strategies for how you make your masks or gowns or other face eye protection last longer, and how you use them more than one time. So I will add that CDC link in there. Okay. If you're having trouble getting your PPE, then you'll document. It doesn't have to be anything fancy, but your attempts to procure additional supplies, because if you need to go to a regional healthcare coalition or to some other state source, they're going to want to see that you tried to procure those supplies. And for face mask and face mask alternatives, you'll follow the MDH guidance on face mask as a source control, and there is a link to that document there. So this is the base policy, and I'm just wondering at this point if anybody has anything that sticks out to them that you think we should change right away, or if you want Roni to send you this draft so that you can take a look at it and give comments after. What's your preference?
Hi, this is Cindy. So we're trying to work on our policies right now. So I guess if you could just send that out, it would be great, because then I can pass it along to my boss to in our infection control to work on it.
Okay.
Thank you.
So if we get out some drafts, then you can change it to what works for you, yes?
Yes, that would work that would be great.
All right. Someone else in the comments said they'd prefer to have drafts routed. Okay, we'll do that then. So I will pull that one down and pull up the next one. Let me get rid of that one. All right, the next one. This is a participant and staff screening policy. So we have in here that staff will be appropriately trained on infection control procedures and prevention practices, which I know many of you already do. You'll want to have that documentation updated and ready if a regulator comes on site. And then your staff will be screened before entering the building for the shift. So they will also complete hand hygiene, they'll have their temperature taken, and they'll be screened for signs and symptoms of COVID. Then it has in here that if they have a fever of 100 degrees or greater, then they'll be asked to not work their shift. And that will be reported to whoever the program designee is for that. And then you want to keep a log of staff so that you can follow up with them periodically throughout that time to see whether or not they've had other symptoms develop, if they've been tested, because all of that information is going to help you do one of two things. One, if someone comes up positive or is suspected of COVID, that will have to be reported to the health department. And number two, you're going to need to decide when this person can come back to work within the program. And so it's important to know whether or not their symptoms have worsened, have become lessened, or whether or not they tested negative for COVID if they went in for a test. There is an employee return to work criteria. There is a non-test-based strategy, and there is a test-based strategy. So if the employee chooses to go the testing route, then that tells you exactly how to do that. And if they decide not to go in and be tested, then it tells you what that symptom recovery looks like and when they can come back to work. So the non-test-based strategy is they have to be 3 days without a fever, and they can't be using any fever-reducing meds. Their respiratory symptoms have to be better, and it has to be at least 10 days since their first symptom appeared. So let's say they have a fever, and on day 4, they have been 3 days without a fever, they have no respiratory symptoms, they still can't come back to work until day 10 because it has to be 10 days since their first symptoms, if that makes sense. Now I get a lot of questions on this, so as you go through and start doing your implementations, feel free to shoot out a question, give me a call, text, email, whatever, and certainly we can walk through those. There is a test-based strategy as well. So again, resolution of fever without fever-reducing medications and an improvement in respiratory symptoms, and they need to have 2 COVID negative tests, and the test specimens need to be collected 24 hours apart or more. And there's a link within the policy for the testing guidance so that you have that. So if you ever have issues with trying to decide how to bring somebody back from work if they've developed symptoms, you can go ahead and reference the policy. Now, if you have somebody that went in and was tested for COVID, it came back positive and they have no symptoms, then this is the criteria you'll use to return to work. So I put the criteria right in the policy so that there's an easy reference place for everyone, because it gets a little confusing with symptoms, without symptoms, test strategy, symptom strategy. It's just a little crazy. So hopefully those will help. And if you have questions, we'll have to just take those as they come, and you'll have to ask as you go, because it does get a little confusing for people sometimes. For the participant screening, the participants will be screened 1 time a day. That's going to be upon arrival to the program. And it goes through that they'll have their temperature and O2 sets taken. They'll be monitored for respiratory symptoms. And then anything with an O2 set of 90 below or a temperature of 100 or above, and then or presence of symptoms, that's going to be reported to the nurse or designee. Who do you want me to put in here?
Would people want the program director to be put in there?
I'd say the program director.
Okay. Transmission-based precautions will be implemented, and you'll start your process for assisting the participant back home or away from the program. So that's what we'll do for participant screening. Okay.
So
And
do you
then-
have to use the temperature, or is that just something that like you're proposing for this policy?
No, that's in regulation.
Okay, because just like, so I'm connected with Fairview. So for our patients, for our outpatients, we're just asking them screening questions. We are not taking their temperature.
Right. And so this is based upon CDC and MDH guidance for congregate settings.
Okay, yep,
Yep.
so, okay,
Yep. Different
Thank
set
you.
of people. Yep. You bet.
thank you.
So then there's a process for if the participant has a suspected or confirmed COVID infection. Now you're probably not going to have a confirmed because hopefully that person wouldn't come into your program with a confirmed case. And if someone was tested, one would hope that they wouldn't be coming to your program until the results were back. But in the event that someone comes to the program and someone calls up and says, oh, you know, we tested them 4 days ago and we just got the results back and they were positive. That's why I left that in there. And it gives those directions here. Now I have them highlighted in yellow because these are just some suggestions or some things that are in the policy. Certainly these are not in regulation, and you can adjust these for what your process is going to be in your program. So I left them highlighted as a place to really pay attention and take a look, because you may not want to do all or pieces or parts of this. So just take an extra special look at those highlighted areas. If you find that a participant is COVID positive, we're going to contact MDH. If you have people that you find that are more than one that are symptomatic on a day when they come, or if they become symptomatic during the day, you can cohort those two participants together so that they can wait for someone to come and pick them up, or they can be brought back to their home. So I have the cohorting in here in the event that you have more than one person who develops symptoms in the same day. Droplet precaution is again, PPE again, when leaving the participant's room. So if you've got them cohorted and they have got symptoms, when you do that, it talks about taking off your PPE and putting them in an appropriate receptacle. So I didn't really know what other word to put in here besides room, because I know they don't have a room there, but if they become symptomatic, you'll put them in a separate area. So whatever verbiage you want to put in there, you can. I wasn't sure what you wanted. And if possible, you can dedicate non-critical care. Like if you need to have somebody that you think is really having trouble and you need to monitor a temp or something like that. This is likely not going to happen for you guys, except for maybe the bedside commode or something like that. But I put it in there because in the event there is something that you would have to use for a participant waiting for someone to come and get them, like a commode versus a toilet, that you would be able to have something available if need be. And then if use of other common items is unavoidable, then we'll clean and disinfect them before use for another participant. Then we've got discontinuing transmission-based precautions for participants and allowing their return to the program. Again, there is a symptom-based strategy. There is a test-based strategy for participants that had symptoms. And then there is a time-based or test-based strategy for participants that did not have symptoms, but did have a laboratory confirmed positive case. So by putting those in the policy, number one, it meets the need for your policy, but number two, it also gives you a place to easily reference these return to work and return to program strategies without having to dig around for the guidances. So that's what I have in for the the staff screening, participant screening, and suspected or confirmed case. I put them in the same policy because it seemed to go that way for me when I was writing it. Certainly can break them up and have them in 2 different policies. Does anybody have questions or comments on this piece?
Kari, can you talk a little bit more about the testing for the oxygen level and what that looks like and what providers would need to get to be able to do that?
Yep, so the oximeter, it's a pulse oximeter. It's a small device that fits on your finger. And usually what we're saying is if anybody has SATs below 90%, that may be an indication of a respiratory issue during this time of COVID, and that may be a reason to have someone leave the program. Now, I will tell you that sometimes if you have nothing else besides a low O2 SAT and you have no temperature above 100 or above and you've got no respiratory signs and symptoms, sometimes you may want to have them take a couple of deep breaths or something like that. Or if they have oxygen, routinely make sure their oxygen is turned on. And if those O2 SATs resolve, then it should be okay. If they don't and they stay below 90%, that may be a reason you want them to leave the program and have someone just watch them for a couple of days to make sure that they're not going to develop any other symptoms.
And where do people just at a medical store? Or?
Yeah, medical supply store, or if you work with McKesson or Medline or Elam or anything like that for any of your supplies, you can get them there. You can go on Amazon and find a pulse oximeter on there. So Lynette, it looks like you've got a question. Do we have to do the temp screening or can we ask staff to check at home before coming? You have to do the temp screening. It's an active screening. Now you can say to your staff, take your temperature at home, and if your temperature is 100 or above, don't come to work and let us know. But you still have to do the screening when they get there. So you can prevent people from coming into the program, staff from coming into the program by taking their own temperature at home. But once they get there, you still have to screen. Same with the participants. Someone can screen them at home, but that does not remove the responsibility for you to screen when they get there. And then in the chat, Nanette also said that, Amazon has them, Walmart used to have them, and lots of pharmacies will have the oximeters as well. Any other questions about participant and staff screening or a suspected and confirmed case? Okay. We'll get rid of that one. And then last but not least, we have a visitor and vendor screening and restriction policy. So I won't go through this whole same one because it is very, very similar to the participant and the staff screening. But there is a notification of potential visitors of the restrictions. So if you've got vendors or something like that that routinely come, or the mailman or something like that, you might want to put this in and then talk about how you're going to notify them. The rest of it is pretty much the same as the screening for others. There is an exception for essential healthcare personnel. So we're going to want to decide if you've got an essential healthcare personnel that might be coming in. So I don't know if you've got hospice personnel that come into the program or therapy staff or anything like that. You might want to decide who's an exception and they are essential so that you know who you're screening and allowing in and everyone is on the same page. But the screening and the bar from entry is the same. As the other. So any questions on that? Okay, so I will get those drafts out to people. Actually, I'll get them to Roni so that she can get the drafts sent out to everyone. And I will put a draft marker on there so that everyone knows it's the draft, and then you can take it off as soon as you revise it. The other policies that I know that we need are listed, were listed on this PowerPoint presentation. And so I will be looking at a transmission-based precautions one for you. I can do a cleaning and disinfecting protocol. That may have to be tweaked though, because that will be very, very different. So I can do a template for that one, but you'll have to fill in your particulars yourself. And then Roni, were you gonna work on arrival and departure protocols, or were we gonna work on that together? I can't remember anymore.
Yeah, you and I can connect on that.
Okay. So we're taking a look at that. I am gonna just pull up Terry's checklist now. I'm just opening my email, which I had turned off because otherwise it beeps and buzzes and nobody knows what's going on. See, just like that. So I just have to wait a minute for this to open up and load, and then I will pull up your checklist, Terry.
So while we're waiting, what other questions do you have just in general as you're starting to kind of work towards reopening or thinking about how you might want to or if you want to? Okay, well, if some questions arise, just let us know.
Okay, so Terry, God bless Terry Foley for being able to figure out what's in our brains and actually put it down on a piece of paper so that it makes some sense. So she does such a wonderful job with putting together these types of tools. So thank you, Terry, for taking the stab at the draft. And Terry and Roni and I went through this yesterday. So we have a reopening checklist that we've started that's in draft format. And I think we're gonna just put a couple of other things in here, right, Terry, before we send it out for people to look at, like the link to the FAQ and things like
Yes.
that. Okay. So the first thing we've got in here is your COVID preparedness plan and a link to the template that has to be done, and the notification about resuming facility operations and a link to that so that you can check those off when those are done. Then we've got a little section here about determining participants and what to consider. And we'll add in those high risk conditions that we talked about today so that those are in the checklist itself. And then we've got some things here for developing your shift and cohorting plan, your list of probable participants, then go ahead and invite them to see who accepts and declines and record that. And then go ahead and finalize your shift and cohorting schedules. Then there's the communication for transportation options and protocols, communicate visitation restrictions and non-essential volunteers. Then there are, let's make sure that we've got the infection control precautions, the PPE, cohorting, social distancing, all of those sorts of things. We've got an Educare option for training on COVID, and then we'll add that information in there for you. And then a reminder to document the date and time of training to have that available. And then we've got on this page some things for developing your social distancing, putting physical barriers or visual indicators, making sure you've got hand hygiene stations, and posting your implementation plan that was submitted to DHS, or that COVID preparedness plan. Some things for policies here, and then communication of these processes. So this was the checklist we have put together as of today. We'll put in a couple of those areas where we've got things highlighted in yellow. So the screening tool that we have up on our website that we talked about a couple of weeks ago, adding that participant right, adding some links for the Educare, and then adding in those high-risk people, and a link to the FAQ. So once that's done, then we should be able to regroup and review this one more time, do you think, ladies, by the end of the week, and then get this out?
Yep.
Yes.
Okay. So what we have now are, we have an FAQ for reopening that was posted on our website last week, and I believe Roni sent out to everyone. We have 3 policies encompassing 4 different things. I still have a few policies to write that are ADS specific on a couple of other things that we talked about. We've got the checklist ready that we will be able to have out by the end of the week. And
Maybe
we've got,
interested if there's feedback on the checklist, anything that we're missing, and particularly on the communication piece. Is it helpful to have templated letters, or have you already started to develop your own invitations for participation and communicating what you're going to do? You can just put that in the chat, or you're also welcome to jump on. Sorry, Kari, just wanted to get...
no, by all means. Okay. Well, if you have questions or want to put anything, a template, Colleen says a template would be nice to have. Nanette too would love some template letters that can be revised. So it looks like we should do those communications templates. So I will finalize the other policies. We'll get the checklist finalized. We'll get some communication stuff out to you. You have as I said before, the screening tool. So I guess the question from us as a team then is, what else is it that you think that you would like from us that we should work on and that we should have available for you, so to help you with your transition into reopening your programs?
Hi, this is Peg. I'm wondering, is there any specific Metro Mobility transportation information that tells us exactly what they're doing? Because if we have to use that, it'll be, even though it's not our system, is there something we can have that we can send to our families that tells them how they're keeping people safe?
You know, that's a really great question. And I don't think to this point, I don't think we've gotten any information from Metro Mobility, but I'm certain we could reach out and ask them if they have information that they're giving to their riders that we could provide for you guys. And actually, it wouldn't be bad for the congregate settings to have either when they end up having to start scheduling rides during their reopening process when that comes as well. Roni, do you want to reach out to them? Transit Link to Nanette, thanks. Do you want to reach out?
I can definitely do that.
Okay.
This is Cindy again. This is about staffing. So we're thinking, I know I had talked with Peg the other day, but we're thinking of opening for regular adult day, maybe just a couple days a week, and then the other days do the alternative adult day. For staffing reasons, when they talk about staffing, keeping the staff with the same people. So do I have to have completely different staff to do the alternative part versus the in-house part? Does that make sense?
Yep, I understand what you're asking. And no, you don't have to have completely different staff because you're going to continue to screen them whether you do the one-on-one alternative day visit. You'll still have your staff screened versus when you do your in-program days with more participants. And so it's fine to have those staff be the same.
Okay, thank you.
You bet.
Just on a side note, this is Cindy again. We have one of our home health clients had tested positive for COVID-19.
Oh, yikes.
And so really be cautious, like when you're going out to do some of the visits, that we're making sure that our clients are wearing their mask also. And I don't know if everybody's doing that. I know it's really, really hard when you think they're in their own home that they may not need to wear one, but I guess that they should wear one at all times.
Yep, you're absolutely right. Okay, Paul, you asked a question. When transporting participants in a 4-door sedan, can I put one participant in the back seat and one in the front passenger seat? The driver is an employee who will be with the participant during the day doing programming. That is a good question. I would have to reference the transportation guidance because I can't remember the answer to that question. Can you, Roni?
I can't either, but I can include the link in here real quick for that transportation guidance, just so we know exactly where to look for that.
I apologize, Paul. I will, Roni can put the link in there, but if, but if you email me and if you can't find it in the link and you email me, I will help you through that because I don't have your email address. But here is mine in the chat. Okay. Any other questions or anything else that you think that our team can put together to help you with your reopening?
I see a question on the chat regarding oximetry added to the screening of clients on arrival to the center, and that is a requirement, right, Kari?
Yes, and I think we did you add that in, Roni? You were going to add that into the
To the screening? Yeah.
Yeah, to the participant screening.
Yep, that's added.
It's already, I noticed it's already been added too.
Okay, thanks, Nanette. All right, so then I guess before we wrap up my part, I just want to ask if, I mean, was this PowerPoint helpful? Was the review of the policies helpful? Is this something that you want me to keep doing? Were you kind of like, meh, we already know that. I don't need to sit through this, Kari. We're sick of hearing you talk. Just want to catch a gauge because I want to keep offering the coaching sessions if you're finding them helpful. And if you're not, then maybe we could find an alternative way to do that. So can I just have some feedback from people? If you just...
I have a question. On the pandemic plan, it seems to be quite complicated in some areas. Is there any way of getting like a rough draft of that? Because the way that Jill was talking, that we have to have it very, very explicit to our places. Is there anything that we could do as a template that we could just add to on that, on the pandemic plan?
Yeah, you know, Nanette, that's a really good question. And thank you for bringing that up. I think what we could do on Monday, I'll work on a template, but what we could do on Monday too in our normal coaching room time at 11 is we could go through those template sections and talk about what can go in there. Would that be helpful?
That would be very helpful because it's very, very distinct, and the things that she was talking about the other day, we have to be very specific.
Okay, so I will work on a pandemic plan template to help you guys out. I will try to get it out by the end of this week. I've got a little bit of a crunchy week this week, but I will try. If I can or if I can't, regardless, we'll spend our coaching room time next Monday on putting together or talking through that pandemic plan so you guys have a good idea as to what to put in there and how to specifically individualize that to your program. And that's a really good question and a common question. People have trouble with those plans sometimes. So yes, let's please do that. And I'm seeing from people, yes, we're good to continue on with the coaching room. So we will just keep doing them and try to pick good topics for you guys. I like to have you drive the topics because then I know what you're most wondering about and what information you would find most helpful so that I'm not wasting your time. And so we'll try to continue to pick topics and we'll just do it until we find that maybe you just don't need it anymore and it's not worth your time. So you'll just have to let me know how you feel about it. And I'll probably ask every other week or something just to make sure people are still wanting to do something like this. So I think that's it for me, Roni. I'll just pass it back to you. We've got 12 minutes left. You know, and as we said, the coaching rooms will go as long as they need to go. So I'm just going to give that back to you.
Okay, great. Thank you, Kari.
You bet.
So plan for us to send out some of those sample policies that Kari walked us through today. Feel free to send back any feedback. We'll try and get a final version out by the end of this week. So send us back your feedback kind of in time for that. A quick reminder of a couple upcoming things that we have kind of happening this week. One is I emailed you all a link to a survey that closes on Friday. That's really intended to try and understand the impact the closure has had on your participants and family caregivers. And we think this data will be really helpful for us to use with our with stakeholders and legislators, and to really show the impact of the service. So please, if you haven't already completed that survey, please do so by the end of the day on Friday. We also will be hosting our weekly Adult Day Huddle, which will take place tomorrow at 3:30. Again, Jill Slyke from the HCBS Licensing Division will be there to walk through the Adult Day guidance and to answer questions. So it's a great opportunity to hear directly from DHS what their expectations are and what their intentions are behind some of the requirements. I'm going to just pop over real quick to some of the chat questions that have come in. A question from Tiffany about exceptions to the cohorts. There is not currently an exception to those cohorts, so they are limited to 8 people, including staff. But that is one of the things that we've identified for DHS. I know Jill was talking about kind of a turning of the dial for Adult Day guidance as well, and that's an area that we'll be requesting a higher number for those cohorts. So it doesn't look like there's any other questions coming in. We'll plan to see you tomorrow at 3:30. We did record this call today, so I'll be sending that out later on. Hopefully all the technology will work for me to be able to send that out to you later on today. And then as always, please reach out to me, to Kari, to Terry, who's been amazing in helping develop all of these resources. And we're just here to help. So have a good day, and we'll see you tomorrow. Thanks.